Okay, the question is now how to treat a patient 65 years old or older with type 2 diabetes and obesity. So this is my disclosure. And as we can see, the prevalence of diabetes is increasing worldwide. And in the future, we may see an increase of almost 48% independently of gender. At the same time, we see also an alarming increase of obesity also worldwide. And within the European region, Greece is at the top concerning prevalence of obesity. Among 650 million people with obesity, around 30% have type 2 diabetes, and among 425 million people with diabetes, around 90% have overweight or obesity. Obesity and diabetes seem to be syndemic, and just to remind you that syndemic means two or more conditions that interact synergistically and contribute to the excess disease burden in a population. What happens in this obesity and diabetes endemic? Obesity promotes insulin resistance and beta cell decompensation, which are the main causes of diabetes. In addition, the sleep disorders, the inability to be active, and the stigma and impaired mental health also worsen the condition of diabetes, which in turn helps to increase obesity due to medication-induced weight gain, due to neuropathy and decreased activity, due to hypoglycemia and stimulation of food intake, and also stigma and impaired mental health plays also an important role. Additionally, physical environment and social environment act also synergistically in this case. Many different associations recognize obesity as a disease, and 90% of health practitioners recognize obesity as a disease compared to only 17% of patients that believe that obesity is a disease. Why? The question is here. Only a minority of the people, independently of gender, care about the health compared to the social media, which are the top of our interests. That's why they cannot recognize obesity as a disease. Now, the question is how much weight loss is needed in order to improve the obesity-related complications, 5%, 10%, 20%. Progressive weight loss has dose-dependent and tissue-dependent biological effects, and the benefits increase according to the percentage of weight loss. The greater the percentage of weight loss, the more the benefits, as it is shown on this slide. Now, the question is, what are actually our targets? Diabetes remission or obesity resolution? If you ask me personally, I think both of them. And if actually diabetes remits with 15% weight loss, then what is the target? As we have seen previously, the greater the weight loss, the more the benefits. This very interesting review refers to diabetes and obesity as one condition called diabesity and suggests that they should have combined treatment strategies. And now to the question, if we have a patient, 65 years old, with type 2 diabetes and obesity, which is a very usual case in everyday clinic, how to treat this patient? For the first time, the consensus of ADA and TSD is referring to the obesity as a medical problem. And by 2030, that means in the near future, we may see an increase of almost 50% in obesity and of almost 25% in morbid obesity. And what are the goals of diabetes care? To prevent complications and, of course, to optimize quality of life. For preventing complications, however, glycemic control is needed. And in order to achieve it, we have to describe medications with proven cardiorenal protection. Weight management is also a very critically and important aspect of disease management, which in turn helps to mediate cardiovascular risk factors. And according to this consensus, weight reduction has mostly been seen as a strategy to improve glycemic management and reduce the risk for weight-related complications. Weight loss of 5 to 15% should be the primary target in management in people with type 2 diabetes. Of course, a higher magnitude of weight loss confers better outcomes, and many times we see that it can lead to remission of diabetes as well. For the achievement, however, and maintenance of weight goals, we have to set individualized weight management goals and to choose glucose-lowering therapies according to our consensus with high or very high dual glucose and weight efficacy. And among all the glucose-lowering drugs, GLP-1 receptor agonists seem to have a dominant role in the treatment of obesity and diabetes as well for the time being. As you understand, dear colleagues, we are probably living in a new era of targeted treatment for diabetes and obesity, which are the twin epidemics of the 21st century, and both are complex health issues. And as such, advanced treatment approaches are needed, and of course, new scientific developments. Indeed, in recent years, have been made significant advances, and a range of options is available now for the treatment of these conditions, diabetes and obesity. But the question is, why can we get rid of obesity? The answer is here, because today's environment is very obesogenic, meaning that it promotes obesity through different factors. The sedentary lifestyle, the lack of exercise, and convenience food being very calorically dense are factors that promote obesity. And don't forget also the genetic predispositions. Some individuals may have a higher likelihood of becoming obese and pass on this likelihood to generations to come. And on this slide, you can see all the available anti-obesity medications, and between them are also the GLP-1 receptor agonists. However, as I have already mentioned, the GLP-1 therapies were the breakthrough of the last years. And on this map, you see all the current and future treatments based on GLP-1 receptor agonists. This GLP-1 receptor agonist, as it is known, can lead to a reduction of food intake, to a reduction of glucagon secretion, to gastric emptying, to reduction of gastric emptying, and also to increase the feeling of satiety and the increase of insulin secretion. There are additionally more different molecules with diverse metabolic actions in combination with GLP-1 receptor agonists. What about this GLP-1 receptor agonists? We have available the short-acting and long-acting, and both of them can lead to an improvement of glycemia and also to a reduction of body weight and blood glucose levels. Liraglutide was the first GLP-1 receptor agonist studied for the treatment of obesity. And the scale trial showed that the use of liraglutide at a dose of 3 milligrams was associated with reduced body weight, and the participants could maintain their weight loss also during the follow-up trial. Additionally, we see in this study an improvement of glycemic control and also reduction of insulin dose in those treated with insulin in combination with different other anti-hyperglycemic medications. Weight loss is very difficult, we know it, but weight loss maintenance even more so. That's why if we combine exercise, that means lifestyle medicine with a GLP-1, then this combination can lead to a marked reduction of body weight, as it is shown in this study. Another very usually nowadays GLP-1 therapy is the use of once weekly injectable GLP-1 receptor agonists, which are semaglutide and dulaglutide. As you know, both of them are available on the market for the treatment of for diabetes and obesity as well. And we see that the use of semaglutide led to more pronounced reductions of HbA1c compared to placebo. And also we see a mean weight loss of almost 10% in patients with type 2 diabetes and overweight or obesity. And a great proportion of patients achieved to lose a weight of more than 5 or 10%. But the same beneficial effect we see also in overweight or obese people, but without diabetes, and we see a great reduction of almost 15% weight loss, and a proportion of 86% could achieve a weight loss of more than 5 or 10%. The same beneficial effect we see also using dulaglutide, the other one, once weekly injectable GLP-1, great reduction of body weight, and also an improvement, in glycemic control. So the introduction of GLP-1 agonists actually increased the scientific and clinical interest in incretins. The next step was a combination of GLP-1 with another incretin that we can improve further the beta cell function, and so we may see a more effective treatment results using this combination. And studies suggest that this combination could have additive or even synergistic effects for the treatment of diabetes. One of these combinations, the only one for the time being, is tirzepatide. It's a combination of GLP-1 and GIP, and both have receptors in the hypothalamus and brainstem involved in the regulation of energy intake and body weight, and that's why can this combination lead to a reduction of body weight. The Surmount study shows that the use of this combination in patients with type 2 diabetes can improve glycemia and also can lead to a great reduction of body weight, and also in participants without diabetes but with obesity we can also see a marked reduction of weight loss. In addition to all the available drugs, more and more novel medications are emerging for the treatment of obesity and diabetes as well. One option is the oral semaglutide. Oral semaglutide, as add-on to other antihyperglycemic drugs, can lead to a great reduction of body weight and also to an improvement of glycemia. However, there is a problem for the time being concerning the absorption, concerning the degradation in the stomach and the limited permeability across the gastrointestinal epithelium. That's why it's needed to add an absorption enhancer in order to promote the absorption and to increase the bioavailability of this oral drug. Another option is cagrilintide, which is a human amylin analog. And just to remind you that amylin is a neuroendocrine peptide hormone and is co-secreted with insulin from pancreatic beta cells in response to food intake. Amylin activates areas of the brain involved in appetite regulation. That's why can lead to a reduction of body weight. And use of this cagrilintide can lead actually to a great reduction of body weight, but we see a progressive decrease in all active treatment groups, and also we see an improvement in glycemia as it is shown from the different studies. Another very promising option is the combination of cagrilintide and semaglutide, and both can increase the stability of this once weekly injection. Both of them and the combination of them regulate food intake by acting on hypothalamus and brainstem, and so can lead to the reduction of body weight. This combination, as it is shown in this study, can lead to a great reduction of weight loss compared to sema or cagrilintide alone in type 2 diabetic patients with obesity as well. And we see also an improvement in HbA1c level using this combination compared to semaglutide and to cagrilintide alone. So another promising option is the triple combination, GLP-1, GIP, and glucagon, this is the retatrutide, and this triple combination, as it is shown from the different studies, can provide effects on body weight and glycemic control, on hepatosteatosis, on cholesterol, energy expenditure, and lipolysis as well. It's a very promising triple agonist molecule. The use of this triple combination actually, as it is shown here, can lead to great reduction of body weight, and also a great proportion of patients, actually almost 90%, could achieve their target to lose weight of more than 5%, and almost 80% could achieve a weight loss of more than 10%. And additionally to the reduction of body weight, we see also an improvement in glycemia using this triple combination. This very interesting review aimed to highlight that the obesity management should be a primary treatment goal for type 2 diabetes. And it is actually the right time to consider the addition of substantial weight loss as a principal target for the treatment of many patients with type 2 diabetes. And reaching to the conclusion of my talk, there is actually accumulating evidence indicating that the next few years will be a period during which novel pharmacotherapies for obesity will revolutionize the way we treat diabetes and the way we treat the obesity-related complications, between them also diabetes. Of course, it also remains to be seen whether precision medicine may offer personalized solutions to individuals with obesity, and whether it may represent the future of medical weight management, along with the development of novel, very potent anti-obesity medications currently in the pipeline. What are the key points? Treatment of both obesity and type 2 diabetes can be addressed simultaneously with the use of weight-reducing anti-diabetic agents. That's why weight-reducing anti-diabetic agents should be prioritized. Emerging anti-diabetic and anti-obesity medications have greater weight loss potential, which will help close the efficacy gap between medical and surgical management of type 2 diabetes with obesity. And of course, type 2 diabetes and obesity treatments may be best suited for precision medicine approaches rather than a one-size-fits-all paradigm. So, setting all these novel pharmacotherapies in the center of discussion, a patient 65 years old with diabetes and obesity seems to be treated in a much more charming manner than before. And with this, I would like to thank you for your attention.